so often that anybody who has any kind of pain in any part of the body will, and be it what age, even if it is a young child or a young woman, premenopausal, and I just want to add that premenopausal women actually are protected from acute gouty attacks because estrogen is uric, whatever, anything, even a headache, and a lot of people will come to you with a uric acid level. Not all high uric acid levels cause symptoms, and not all of them should be treated. So, what do you mean by persistent hyperuricemia? Obviously, you've had a high uric acid levels and they're not going down. You must evaluate for potentially treatable causes first, particularly for any lympho or myeloproliferative disorders. Simpler things like psoriasis or vitamin B deficiency, lead nephropathy, lead exposure is important. Who should you consider for treatment in asymptomatic subjects? Asymptomatic, which means that this patient has never had an acute gout, has no evidence for any nephrolithiasis or urate nephropathy, no tophi. Persistent hyperuricemia, more than 13 milligrams percent in men and 10 milligrams percent in women. These high values may carry some nephrotoxic risk. If you measure the excretion of urinary uric acid and it is more than 1100 milligrams per day, this has a 50% increased risk of uric acid calculi, and you should use allopurinol if after dietary restriction the uric acid excretion doesn't decrease to less than 1000. Dose should be adjusted to reduce nervous कर दिया. Dose adjusted to reduce uric acid excretion to less than 800 milligrams per day. And of course, consider treatment in people who are receiving radiotherapy or chemotherapy, where you may be expecting or anticipating tumor lysis syndrome with uric acid nephropathy. Please treat these patients, otherwise complications will set in, like recurrent gout, joint deformity, renal failure, nephrolithiasis. Patients can come in looking like this, and we've had a few patients who have. Briefly, these are not available here, but this is a xanthine oxidase inhibitor, FDA approved, febuxostat. Emerging therapies are like urate oxidase, which is a PEG modified mammalian uricase. You have some drugs for signs and symptoms of gout, which is acute gout, which is not responding to traditional therapy. IL-1 inhibitors have had very good results in some case series. And they may be indicated in patients with absolute relative contraindication to treatment with NSAIDs, colchicine, or corticosteroids. I really like this photograph. When we're trying to navigate our patients through their diseases, we must be very clear about the signals we are giving them. Otherwise, they're going to land up like this poor woman did. So how can we do that? We need to keep ourselves updated. There's certain very good prevention and patient education resources which will help us to spell the sign better. These are the resources, and hopefully it will tip the balance in the patient's favor. Thank you.
Speaker is Dr. Terence Gibson, who is from Guy's and St. Thomas Hospital, London. He's going to give a state-of-the-art talk on psoriatic arthritis and modern management.
Thanking Abid and the organizers and the sponsors of this meeting for inviting me and for your kind hospitality. It's a super meeting. I want to congratulate you all. So, my remit is to talk about psoriatic arthritis, which is a particular interest of mine at the moment because it has the potential to provide us with clues relating to the etiology of different arthritides. It is a template almost because it masquerades as a number of different arthritic conditions. It's so heterogeneous in its presentation. I can't see my slides coming up, but I dare say they will in a moment. My first slide is just a little history and classical allusion to the derivation of the word psoriasis, which was actually known in biblical times as a scaliness.